Patrick, who is going to impart some of his many years of valuable information with regards to complications. So Patrick, thank you.
Oh, thanks, Sharon. We do go back a long way, you're right, 20 years or more. So I've quite a lot of slides. So I know that this is a learning opportunity as well. So what I'm going to do is run through the last 20 years and the problems we had and how we faced them and how we dealt with them. It's easier now, I suppose, in this present generation because you know how to fix things. But in the beginning, we didn't. Is that last for me? It's yours, I'll take it. Thanks, okay. So, that's me. And that's an up-to-date me. So I'll just start with Botox, because usually you don't have too many problems with Botox. But in the beginning, when we had it, we did have problems and people didn't know how to address them. This is 1998, and this was an eyelid ptosis that one of my colleagues had seen and thought that it was possibly permanent. At least she told that to the patient. And in the beginning, we didn't really know how to use iopidine, but I also had a situation where I had doctors writing into the Irish papers saying that Botox was going to cause problems for a generation. So I was asked by the Irish Medical Times to do a series of articles on Botox, and as I see, I had sort of said that it's going to be the wonder drug of the 21st century, which it did become. So with Ptosis originally, here's one that we had as well, and iopidine wasn't up and running really then, and originally I used phenylephrine, which works fine, because we know in hospitals, when we were looking at the back of eyes, we used this, and if you had ptosis in patients that required surgical correction, it worked. And it works well, except that it causes pupil dilatation, so as a consequence. But if you want to see whether iopidine works, because it doesn't kick in for 15 or 20 minutes, you pop in some of this, it's very easy to get, and it'll show you within a couple of minutes whether it's working. So we switched over to iopidine, and these are the different, I suppose, grades of ptosis. So at that stage also, I was dealing with blepharospasm, where of course Botox comes from, and this patient presented here, and I was brave enough to put some Botox into a pretarsal area, because we know the Botox drops an eyelid, but if you've got a dropped eyelid, Botox can also lift an eyelid, because there's two muscles in the bicularis, you know, sort of the pretarsal and the tarsal. So if you inject the pretarsal, everything just there goes back up. And that was her a week later. And you can use this, of course, instead of drops as well, for Botox dropping eyelids. And we use it a lot in Bell's palsy. You know, I really don't run by units very much. So what I normally use is Dysport rather than Botox. And for Dysport, I dilute it 3.5 instead of 2.5. I have my own way of doing it. And it's just 0.1 in terms of volume. I tend to work in volumes more than units. That'd be equivalent to 2.5 to 5 units of Botox, you know. And it works really good. I do these every day with complex Botox, Bell's palsy patients, really complex. You're doing buccinator, you're doing resources, you're doing zygomatic, you're doing DIO, you're doing DIOs. So that was her. Now, the interesting thing is, this is the same as what technique we're doing today. A lip flip. It's exactly the same thing. So your orbicularis is orb, circular, oris around the mouth, oculi around the eyes. So if you do the vermilion border, you'll do a lip flip. So brow ptosis, some of them are that bad that sort of we couldn't correct them. This was a patient who was due to get married that a colleague sort of caused this. So I corrected that, as you can see, by putting in a thread lift. So that was the only way we could do that. Then infections.